Hey guys, welcome back to my channel, and for today's video I'm going to share the challenges or the struggles that I face while working in theaters as a recovery nurse. While I'm sharing you those things, I'm going to make today's lunch, which is my wife and I's favorite. So I bought these two sirloin steak from Tesco. So I've got these two steak for 8 pounds, which is roughly 1,500 pesos. Which is quite pricey, but well, inflation hits, so yeah. Alright, so let's start. So before I joined my current trust, I did review the job description and all. I'm not complaining, but there are tasks and responsibilities that I didn't used to do before or see anyone doing it back home in the Philippines or even in Saudi Arabia. One of the most surprising tasks for registered nurses here in the UK is making a cup of tea, especially in recovery, because back home we normally don't allow patients to eat or drink anything immediately after surgery. I've mentioned this in one of my videos before. Another one, sorry, I had to move the camera because reasons. Another one is collecting beds for patients. So obviously it's a porter job, but sometimes we have to physically collect beds for our patients from the ward or from one of the landings and bring it back to theater. These are the beds where the patients will actually lie on after the surgery. I would say this is unexpected because back home our patients come to the theaters already in their patient's bed, but here in the UK most of the time patients are brought in walking or on a wheelchair, and then in some way we have to bring them back to their ward or shift them to the ward on a regular bed, especially if they are inpatient. In some circumstances, we can transfer the patients on trolleys. They call stretchers trolleys, which was a bit confusing at first. The problem is, as soon as we reach their ward or their room, we have to move them on a regular patient's bed or an inpatient bed. And for patients with bowel surgeries or with bowel incisions, that would be extremely painful, you know, being slid off and transferred every now and then. So we try to minimize that by ensuring that patients will go up to the ward on the bed. This is one of the things that I found interesting, because nurses sometimes have to look for these beds and bring them down to theater, like actually push and pull the beds down to theater from the ward. Now I realize it's not really a challenge, but it's more of a surprise nursing responsibility, added responsibility, but well, I'm not complaining because I just find it interesting. Another added job responsibility for nurses here in the UK is collecting bloods. So back home, from where I come from, collecting bloods is a responsibility of phlebotomists, which are most of the time medical technologists or lab technicians. So whenever we need bloods for our patients, we'll make a request, we call the laboratory, and the personnel will come up to theaters or to recovery and collect the blood, do the venipuncture. But here in the UK, they don't have phlebotomists readily available, so nurses are expected to collect bloods. So nurses have to collect bloods or draw bloods from the patient's veins. But because I work in theater, most of the time this is done by the anesthetists. But in some occasions, in rare occasions, bloods are needed in recovery ASAP, so we have to collect the blood. But in the UK, because everything has to be signed off, you can't just draw bloods even if you know how to do it. If you're not signed off, you can't do it. So next challenge at work is covering areas that you don't usually work in. Like for example, in my case, because I work in recovery, sometimes they ask us to cover the anesthetics for their tea breaks. The thing with anesthetics is, although I was initially interested in joining anesthetics, the thing is I'm not trained to do anesthetic work or anesthetic assistance work. Well, back home we do circulating roles, which includes assisting the anesthesiologist, but it's a different job compared to what they have in the UK. Oh, we've run out of salt. Okay. Alright, I'm gonna reveal that. Nap! Meron tayong asin sa pantry. Nakalagay. Alright, so as I was saying, so how do you open this? Okay, that's so stupid. As I was saying, circulating role in the Philippines is similar, but not so similar to the anesthetic practitioner role. In the Philippines, we have the clerk who prepares the medications, the equipment. Our assisting role to the anesthetist is kind of limited. So all we need to do is literally just help the anesthetist in inducting the anesthetic. In the UK, it's a bit more extensive what the anesthetic assistants do. So they essentially prepare the medications that the anesthetist needs. So that means learning what kinds of drugs are used in this particular type of anesthesia, etc., etc. So I'm not trained for that, and I'm not signed up as well, but sometimes they ask you to cover the anesthetics just for a tea break. Although during tea breaks the surgery is already ongoing, so normally they don't need you to do anything. It's just to actually babysit the anesthetist if he needs some controlled drugs, if he needs some equipment, which are often found in the anesthetic room. So it's up to the person covering the anesthetic practitioner to find where these things are. The thing is, as recovery practitioners, we were not oriented to the location of things inside the anesthetic room, so sometimes it could be a challenge. If you really are interested, then I think you can teach yourself you can orient yourself with the layout of the anesthetic room, but it doesn't apply to everyone. Not everyone is interested in anesthetics, so that could be a struggle, or that could be a challenge to some people. They also ask us to cover admissions lounge as well, which is a very different area for us, recovery, because recovery is supposedly after the anesthetic. So asking us to work before the anesthetic is a bit that will be confusing because we don't know how to do the paperwork pre-operatively. I think one of the challenges that most of us in the trust see in the perspective of recovery, they also assign us in maternity theater, which is basically the labor and delivery back home in the Philippines. So back home, they don't usually ask operating room nurses to recover patients after a normal delivery or episiotomy, or even if the patient had a spinal. It's usually just the midwives who do that, or the maternity nurses, I don't know what they're called, or labor ward nurses. But here in my trust, they would assign recovery practitioners to cover the area, which is, well, it makes sense because the patient was given anesthetic. So basically, a patient trained in anesthetics will have to be there. It's just that sometimes we don't have a good number or enough number to cover that area, and the main theater sometimes suffers because of that. Why it's taking me forever to refill this thing? Maybe I'm not doing it right. So related to what I said, the next challenge in recovery is understaffing, but I guess the entire UK is having this problem. So all of the wards, I think, are already understaffed. And a special area such as recovery, where the ratio is supposedly 1:1, having an understaffing problem is a bit hard for everybody. And if you remember my old videos, I used to sound cheerful. I used to be very grateful that the ratio is 1:1, but because of recent events, this 1:1 ratio doesn't happen every day. One of the reasons is that more staff are getting sick, or they are on their annual leave, or for some other valid reasons. So we have to rely on bank and agency, but even the bank and agency nurses are not always there. So yeah, sometimes the ratio becomes 1:2, 1:3, and that's quite, well, I told you before that I'm used to that kind of ratio, but then, the thing is, deep inside that is not safe for everyone. That is not the ideal. So at the back of your mind, you just think that this is not right. So the next challenge, working in recovery, the on-call shifts. So not all hospitals are the same. Some hospitals, they do have regular night shifts for recovery, but my trusts happen to be one of those that don't have that kind of shift. So what we have instead are on-call shifts, night on-call shifts. And these usually start at 10 o'clock during the weeknights until 8 in the next morning. For weekends, currently we have 7 p.m. to 8 a.m. What is the problem with on-call? I've been doing on-call before, but this one is different. In my previous hospital, when you are on an on-call shift, they can't call you past 10 p.m. But in my current trust, you are on call for the entire shift. So in other words, the hospital holds your schedule or holds your night, something like that. The good thing though with the on-call here in my current trust is that whether you get called or not, you will be paid. Back home, if you don't get called, then obviously you won't be paid. It's more of like a no work, no pay policy. But in this trust, you are paid every hour that passes as soon as your on-call shift starts, even if you don't get called. And the rate varies depending on the day that you are on call. So normally weekend on-calls are paid higher than weeknights. If you are on call, you are expected to arrive at work within 15 minutes or 30 minutes, whichever is more reasonable. And the reason why we get called as recovery practitioners is because the anesthetic practitioner must always be ready if ever there's an emergency case in maternity or any of our CPOD lists. So they should be available to attend with the case. I forgot to mention that anesthetic practitioners are trained, well, not all of them, but most anesthetic practitioners are trained to recover patients in theater or in recovery room, but not all recovery practitioners are trained in anesthetics. I don't think many of us are, but yeah, I can see the challenge is that not all of us are happy with on-call, especially with little kids at home. So this might be challenging for them. For me, I'm still able to do a lot of on-call shifts because my wife and I don't have kids yet. Whenever I am free or whenever my body's capable, I'll just pick up the on-call shifts. So the fifth challenge in working in recovery is the same with any other areas in the hospital. It's chasing after doctors. Sometimes being a patient advocate is challenging, especially if the doctor didn't prescribe any potential or possible medications that the patient needs. And obviously as a nurse, you're not allowed to give medications that are not prescribed. It's not that easy to escalate sometimes, especially during the night when it's just you and the patient. Nobody can help you in recovery. The surgical team, they might be busy with an ongoing case and you can't just pull out anybody. There are some doctors who forget to prescribe things that will be needed post-operatively, especially antibiotics or any of the patient's regular medications or blood thinners. Doctors even forget to do the discharge letter. These things, these post-operative things, post-operative instructions are not technically for the recovery nurses to carry out, but then it would be, I'm just thinking of the ward nurses who I will give the handover to. Imagine being on their shoes and, having incomplete plan of care, and the fact that in the ward it's also difficult for them to call for doctors and the ratio is much larger than what we have. So as long as I can chase after the doctors, to complete their plan of care or complete their documentation, I would do it. I mean, I'm a nurse after all. I know how it's hard it is to work in the ward, but sometimes there are just moments or there are just days when the doctors are really they could really get into your nerve. When the doctors get really, I don't know, too busy maybe, or they just don't care. Some even get annoyed when you chase after them. Like, it's not my fault that you forgot. I mean, I'm trying to help you by reminding you to fill up these things. Okay, this steak is very angry. I'll add some rosemary in there. Yeah, rosemary. My wife and I like adding rosemary to our steak because it gives a better aroma. Wait, when did this turn to a cooking show? I also have to chase after the doctor because he forgot to write his signature. Simple things like that. No signatures at all. Or because the dates are missing, especially with prescriptions. You can't just... In the UK, they're very particular with their drug prescriptions. So as a way of helping the ward nurses, I try to make sure that the prescription chart is complete as possible. If I can do that, I will. Some nurses in the ward, they just don't bother chasing after doctors if they see that a prescription is wrong or incomplete. I could understand because they're too busy to chase after doctors. I mean, the ratio and everything. Sometimes as simple as oxygen is also not prescribed. So in the UK, even 1 liter of oxygen must be prescribed because, well, in the NMC standards, oxygen is a drug. So regardless of the flow rate, it must always be prescribed. But sometimes there are anesthetists who don't prescribe the oxygen. So you need to remind them again, you need to chase after them. Especially sometimes when the patient comes in recovery, they don't have the entire paperwork. So you can't immediately see what is missing because all you have is the patient. You don't have the paperwork yet. So you don't know what is lacking or what is missing. And you can't just keep the anesthetist there just because the document is missing, because they need to prepare for the next case. So things like that can be a challenge. Number 6 on the challenges that I notice in recovery is when you have a patient who doesn't speak English. It's a challenge because when they're under the effects of anesthetic, it would be a struggle communicating with them, and the fact that they don't speak much English, that would complicate things, and you don't really understand what the patient wants or needs. You can only base it from their facial expressions. So obviously, you know that they are in pain if they are wincing, their vitals are shooting up. At least you have an idea that the patient is in pain. Supposedly, these patients have to come in with interpreters who are booked before the surgery, but in emergency cases, these don't just happen. What we often do is we ask any colleagues who speak the same language as the patient, but we only have limited nationalities in theaters, and they're not always available, they're not always around. So it's kind of a struggle. Number 7 challenge in recovery is when... Ooh, all burned up. I think I put it too hot. 7th challenge is when you have a pediatric patient. So especially considering that I am trained in adult nursing and I am a registered adult nurse, having a pediatric client waking up of a general anesthetic, that would be really scary sometimes. And in our trust policy, it usually requires 2 registered practitioners to stay with the patient. But this is ideal. And when you say ideal, it doesn't always happen. So what makes kids extra scary is the fact that they are really unpredictable. Some kids behave well, some kids don't. Some kids jump off the bed when they wake up and they don't see their parents. And especially if you have a patient with a fracture or a broken ankle, broken bones, and they start to flip around, that would harm their limbs. They might hurt themselves. So what I often do, I would call the parent, I would call the caregiver as early as possible We only call the parent once the patient is awake of the anesthetic or once the patient artificial airway has been removed. Most of their medications are based on their body weight, so you have to calculate everything or most of the things that you would administer to these kinds of patients. But on the bright side, sometimes kids can actually be really sweet. Well, kids are generally adorable. It's just, you know what I mean. Aside from kids, another challenging type of patients are IVDU, so drug users, drug abusers. What makes them challenging is because they have high tolerance to opiates. So these are powerful painkillers. So obviously after surgery, they would require painkillers, but because they have abused the drugs before, they're not going to work effectively anymore. So these patients actually require different types of drugs. You may have to expect a different kind of painkiller, something that you're not used to giving, or sometimes the patient would ask and ask and ask for painkillers because they just don't work. And you need a high amount of patience because these types of people, sometimes they just don't listen to you. They can be so really impulsive. They won't listen, they won't cooperate. They will insist on going home even if it's not safe, or even if it's only been minutes since they woke up from their anesthetic. And the last challenge that I find in recovery is supervising students. So why is this a challenge? Because back home, we have clinical instructors who are employees of the university where the student is enrolled, and they are in charge of overseeing the students' progress and students' activities. So they prepare examinations, they prepare plan of day, teaching lessons. But in the UK, you can't expect a clinical instructor. So it's the staff nurses who are actually in charge of supervising and mentoring the students. Well, the thing is, not everybody is confident and competent in teaching students. Although I do appreciate the students, they're really great assets in the area. They would help you with tasks as long as they're allowed to do them. I would ask the student to run gases for me, or if I need additional fluid or I need additional equipment, I ask the student to get it for me because I cannot leave the patient alone in recovery. I do try to impart some things that I know to the students, hopefully that they could pick it up and will learn from my experience and from what I know in my previous training. There are also great resources for, especially when you're struggling with the colloquial language, with the slang, with the terms that Brits use, because of course you're not used to these slang, you're not used to these words, so the students can actually interpret them for you. Right, and my steak is done and it's ready for lunch. No, wait, I have to add some buttered vegetables, mixed vegetables. That's the end of my list. So those were the 8 challenges that I noticed or I experienced in theaters while working as a recovery nurse. If you like this video, click like and subscribe, and try to visit my channel. I'm also on TikTok, by the way. I'll post the link. Thank you for watching. See you next time. Bye bye. Oh, rats.